right, I think that's 30 seconds. I'll get started. Thanks everyone for attending. My topic today is titled Physician Efficiency in the Emergency Department. Are you seeing enough patients? Admittedly, a controversial title. Let me just see. So first off, no financial disclosures on myself. My main disclosure is I put that topic in mostly as a hook. I wanted to incite a bit of morbid curiosity as to what Frankish was going to talk about today. I'm not actually going to tell you if you're seeing enough patients. Amy thinks I picked this topic due to what she calls my German efficiency. I'm notorious for dissecting how we accomplish household tasks and trying to come up with a faster but equally effective way to do things, which annoys her to no end. But I do take a fair bit of pride in being able to move people to the ED in a timely manner when we get these huge roadblocks put up in that respect. So I think it's a good topic to talk about. Every physician's different, and as such, we each have a maximum speed that we can safely work at. But I think we all probably have some room to improve on that and top that speed out a bit. Mario Andretti was quoted as saying, if everything seems under control, you're just not going fast enough. So this is probably a more appropriate title for what I'll talk about today. Physician productivity in the emergency department. How do we measure it and how do we maximize it? So before I can get started, mandatory cute kid pick is always required. So here's Lucy and Eva. Lucy's almost 3 and Eva's 16 months. So I don't think we're beginner parents anymore. I'm amazed how fast it goes. I'm sure everyone with kids older than them would tell me the same, to just watch out. It just flies by. All right, so this is what we're going to talk about today. I'm not going to touch much on system-based strategies to improve efficiency and productivity. And when I say systems-based, I'm referring to things like specialty clinics, like our stroke prevention or our early pregnancy complication clinics, the use of scribes, specialized teams, department kind of setup and zones. I'm going to avoid that kind of thing. They're hugely important. They make a huge difference, but they're slow processes to set up. As most of us know, there's lots of hoops to jump through. And what I really want this to be is more of a tips and tricks on what you can take to the bedside tomorrow. So I think it's a topic we probably don't spend enough time on with our residents. We tell them, don't worry about volume or throughput, just focus on being thorough. You can learn that later. But then how do they learn that? So I think what I want this to come out as is kind of a summary of all the things that the seasoned emerge doc wishes they'd known in the first 5 years of their practice. For the vast majority of us, we just figured this out eventually by trial and error. But when I looked into some of the literature around this, I actually found there are residency programs that have this built in and emphasized in their curriculum. Some actually go as far as to have a flow month where they actually send their residents, usually their senior residents, to a department that's particularly good at patient flow and productivity. And then that entire month is really focused around that skill and learning that. So the first thing I'm going to put up just to get us started off is pulled from an opinion piece on the ACEP website. It's entitled 14 Tips to Improve Clinical Efficiency in Emergency Medicine. And the tips that this author, Kevin Clower, lists are quite good, and I'll go through some of them. But it was his initial introductory statement that I really liked. I think it really hits home on a lot of this. So I won't read it in its entirety, but what he's getting at in this quote is that starts to notice a bit of an increased volume in the early going of a day shift. So he goes over to check with the nurse and make sure that the patient he'd just seen is on his way to radiology, and gets the response back, well, why are you in such a hurry? We aren't that busy. And his response back, I think, is very, very important. How efficient we are now will dictate how we handle our increased volume later. So we can't always control our shifts, obviously. We don't know what we're walking into. We have no idea how patients are going to be spread out and distributed through the shift. But we can control what we're doing with the ones we already have. He describes 2 speeds in the emerge, off and on. And then finally, that slipping into a slow mode during lulls in volume can be a disastrous strategy. So I really liked this initial paragraph he puts up. I love putting my feet up as much as anyone, but I like to do it when we're getting close to having an under control waiting room and we have that legitimate reason to take a breather. You can judge emergency physicians on 2 things. I've heard this quote before a few times. Can you make decisions and can you move the meat? And I'm not trying to refer to patients as meat or dehumanize them, but they're definitely prized qualities among EM providers. So the literature, what was out there? Admittedly, not a ton. So there has been numerous papers looking at departments and health systems as a whole and how they impact on productivity and department flow. Again, they're large system-based things, but there was very little out there about maximizing productivity on the individual level. What I found was largely opinion-based or survey-based studies. So they would ask a large group of seasoned emerge providers ways to improve clinical efficiency. This obviously doesn't give me carte blanche to talk about my opinions on this, but I want you to know that most of what you're hearing today is someone's opinion on this topic, mostly expert opinion. So the first article I'm going to touch on is an article written by an EM physician a few years ago out of Ottawa. It's called Flow Hacks for the Emergency Physician. And he again touched on what I've been noticing, in that it's not something that's implicitly taught to us as EM learners. And then we're kind of meant to absorb a lot of things in terms of how we see flow and how we see volume in the emerge based on just seeing the more senior staff work. And he really touches on what I was saying earlier, is that we just expect everyone to figure it out. So he highlights some interesting areas that have helped him in personally. And I thought he had some really good points here, so I was going to go over them. First off, so I'm sharing this picture here with permission from Dr. Wei. I'm sure all of us have experienced this before. Hands up if you have. I like to dub this the dreaded reassessment land, where you really get taken out of the game for a while. And this is the first thing that Dr. Syed, who writes this article I just put up, mentions. He says, avoid the dreaded reassessment land. So when he talks to learners about improving their flow, he finds that they're often very successful within the first few hours of their shift, and then they start to slow down through the middle and the latter portions of the shift. Now, this is true for anyone, staff alike. We know that if you look at patients per hour rate, it significantly drops off as the shift goes on. And again, a lot of this is because you're constantly reassessing patients you've seen earlier, which is natural and normal in a shift. But his biggest tip he's found is that improving patient flow is hugely aided by avoiding reassessment land. In order to do this successfully, you have to maintain a high cognitive load. So I'll touch on cognitive load in a second about what that means. But essentially, if you can stay out of this reassessment land where you get absolutely like bogged down in reassessments, you can maintain a higher flow as the shift goes on. So his strategy that he employs is, if he has something like 2 reassessments pending, for instance, he'll pick up one of the reassessments, but he'll grab another new chart at the same time. Now, this obviously is at the expense of one of those patients is ready for disposition, and instead you're prioritizing seeing a new one instead of going to see the reassessment. So if your department at that given time needs to free up beds, it's maybe not the best strategy to employ, but there's some evidence to support this from a patient perspective. If you poll patients and ask, they would rather see an MD sooner and then have to wait a bit longer for their tests than the other way around. So that sort of grabbing a new chart every time you do a reassessment does sort of help you to do this. My kind of final thoughts reading on it was, I think the thing that works for me particularly is not to wait on my reassessments. Sometimes all the tests are back and the nurses just haven't had a chance to flag the patient. So if you can kind of sneak in and start picking away at your reassessments and get away from the point where all of a sudden there's 6 or 7 of them pending, you can really stay out of reassessment land. For me, even sometimes I'll notice that there's one stubborn labs waiting, and I know it's going to be normal, but for some reason it's taking longer that day. You can still sneak in and have your discharge talk and kind of get that going. And if you can whip off those reassessments when there's a lull in new patients to be seen, you're really finding the sweet spot of physician productivity in the emerge. You're managing to fill your downtime with a meaningful task. He then touches on grabbing multiple charts, probably something most of us do, particularly in more like lower acuity urgent areas of emerge. And I've always found it advantageous. It seemed natural to me to grab a couple at a time. But something I never thought of that this author touches on is that it creates a bit of a sense of urgency when you've got a stack in your hand. And it also sort of forces you to look at the ones in your hand and think about the best way to see them. So he brings up the idea of a rate limiting step. If you look through your 2 or 3 charts and realize that someone clearly based on the triage history needs some type of a rate limiting step test, like an imaging test or x-ray, that sometimes, makes sense to rearrange, put that one first, even if that's not the order they were up to be seen, because you can get that rate limiting step going, go see the other 2 or 3 in your hand, and then come back. And finally, I'd never thought about it this way, but he alludes to how detrimental interruptions can be to emerge providers, and mentions if you fill your time with patient care, i.e. you're in the room, it's harder to interrupt you. So when you grab multiple charts and you kind of go room to room to room, kind of hide from the nurses in a sense, which it sounds kind of crude, but it is one advantage to having multiple charts in hand is it's a little harder to find you and interrupt you. Finally, he alludes to increase your actions per minute. Now, actions per minute comes from video game terminology, and it refers to kind of the number of moves that a player undertakes in a period of time to outperform their competition. And he likes to use the phrase to describe physician productivity, so that our flow often hinges on how many actions we can undertake in a certain period of time in a shift. But he'll use it to describe to learners that there's always a few more things you can do in an hour time span to reach your peak efficiency and flow. And I like the sort of take home from this. He says, from a medical education standpoint, he actually uses it. So he'll ask his more senior residents, okay, what are you going to do in the next 2 hours of your shift? And I'll have them sort of plan out, okay, I'm going to see this patient on the board. I'm going to reassess this one and I've got this procedure to do. So, okay, great. That's your 2 hours. And then he'll challenge them and say, okay, that's what you're going to do in your 2 hours, but I want you to grab 2 more charts on the urgent side in that 2 hours. And in that sense, he'll sort of train them to build up their workload in a safe manner and be able to sort of work with higher patient flow more comfortably as they get better at it. I touched on cognitive load. So the strategies that are brought up in this do require you to have the capability to maintain a high cognitive load. It's probably the biggest challenge in emergency medicine is trying to maintain and successfully balance a large patient roster. Makes the analogy to lifting weights, exercising, that you can't just go ahead and lift the heavy stuff right away. You do have to build your way up safely, get used to it, get comfortable handling more. In order to do this, you have to know what you're doing with your patients. So he again alludes to kind of creating a mental roadmap of the patient's visit and their kind of journey through the emerge, and really like thinking and having that cognitive exercise with every patient. That, okay, I'm going to do these tests. I think this is what's going on. If the tests are normal, this is the plan. They're either going home or I'm doing this next or they're being admitted. He says, if you can do this cognitive strategy on every patient you see, they weigh on you less. That cognitive load isn't quite as heavy on your shoulders. So you might see that colleague who's got 8 patients on the go and you think to yourself, man, they must be busy. They got so many patients on the go. But if you can do that cognitive strategy on every patient you see, those patients weigh on you less. You've got the mental roadmap already constructed for each of them through the emerge, how their visit is going to look, and it makes it easier to pick up that next chart. So that's the take homes from that article. The next one is an older article. So it's actually from CGEM in 2003. So it's almost 18 years old. It's Canadian, obviously. It was published in CGEM, and it is sort of, again, largely an opinion piece, but it actually bore out of a resident and faculty retreat for the University of Toronto. And prior to that, the infancy of this sort of paper was a senior resident chatting a lot with 2 of the more experienced staff in this department about how do you improve your flow and efficiency. They decided, you know what, this is a big enough topic, let's do this workshop. And this is what came out of it. So they broke things down into physical, cognitive, and disposition strategies. So these were the physical strategies they came up with. Carry the tools you need. I think this is self-explanatory. You wouldn't go into the woods without a compass, but a shift shouldn't be any different. You shouldn't be, heading out onto the floor to see someone for the first time and you're not having all the tools you need, stethoscope, pens. Now we have to put on all the different PPE. I'm probably a little on the type A routine for me, or I have a certain pocket I need my prescription pad in. Pens are always here. But it's akin to sort of preparing for a race or preparing for something. The same with a shift. You want to come well hydrated with everything you need with you and ready to go on time. They talk about embracing technology. And clearly this is 2003, so sort of the infancy of smartphones, but I think it still rings true. The only thing I would add in terms of embracing technology is we almost have technology overload coming up. Sometimes it's really good to learn one app really well and you're a bit more efficient at finding the information you need on that one app as opposed to having 25 at your disposal and you're not sure which one's going to show you the right stuff. They talk about minimizing unnecessary interruptions. This is easier said than done. I mentioned how the multiple charts in hand has this benefit, this byproduct of it. One of the articles I looked at suggested that on average we get interrupted about 11 times an hour as emergency providers. This can be very detrimental when you're in the midst of making a big cognitive decision in your head. I've always strived to, if I get interrupted, the moment I'm done, whether it's signing that ECG, I immediately think, what was I just doing? I got to go back to that. Let's not miss that. And then they talk about the idea of streamlining your movements. So when you head to another part of the department, think about things you can actively do on the way, kind of plan your route through the emerge. this takes me back to my mom harping on my head as a kid. She would leave things at the top of the stairs, and if I would go down to the basement and not grab something on the way, she would be like, Paul, always grab something. I leave them up there for a reason. For me, the thing I do in the emerge is if I'm going over to urgent to see a chart, I always swing through trauma on the way. Odds are I have a patient there. You can kind of do a little like drive-by reassessment of your patients as you walk through, chat with the nurses on the way through and see if they have any like outstanding issues or things that they need. And you can almost head off your reassessments in a sense while you're actually just following the regular track that you would walk over there. So this idea of streamline, or they also use the term choreographing your shift, is where this comes up. And then finally, recognize limited resources of energy. So they allude to having a ready supply of hospital grade snacks for patients to ensure long waits, but particularly this sort of sources of energy thing comes down to attending to your own hydration and nutrition and making sure that you take the breaks to recharge. They emphasize that short breaks, short windows away that are timed around the shift schedule and the patient flow is probably the most efficient way to do it. And interestingly, this was written around the time of SARS. So they allude to how hard this can be when you're wearing PPE and we don't have a water bottle sitting right by you. So I thought that was, oddly fitting given what we're going through right now with coronavirus. Cognitive strategy, so visualization. This is very much what Dr. Syed in that first article was saying about sort of visualizing a patient's path or journey through the ED, projecting the timeline, what they're going to get done, what tests they're going to have done, what you're going to do if those tests are normal or abnormal. Again, that cognitive strategy is very important in terms of streamlining how things go and lessening the cognitive load that your patients have on you. Then timing. So timing, he's talking largely operational timing. So the two big things that come up is rate limiting steps in patient workups. So sometimes, there's not a point to going straight into the room on a patient when the nurses and the RT and everything are in there doing things that are rate limiting equations to that patient's management. You're all of a sudden the less important thing in terms of flow there, in terms of getting in the room. He makes the analogy to a short of breath febrile patient with a provisional diagnosis of pneumonia. They're going to likely need some blood work and imaging. And you can get that stuff kind of going up front and then eventually get in there and collect the rest of the information you need. And in terms of timing, they also bring up the idea of business hours, which I'm glad to see we're getting away from that a bit in radiology, but it is still a thing at our institution that's an important consideration, is that after 4 or 5 o'clock, there are certain services that go into more of an on-call or we can't even access them at all. Neurology is one of these. We have telestroke now after hours. But sometimes when you're getting close to that 4 or 5 o'clock point in your shift, it's worth doing what he calls kind of like business hour rounds and looking through your patients, seeing if there's anything that a diagnostic or consultation service that's going to go into a harder mode to access. Is there anything there that you need? The idea of eyes wide open is gathering firsthand information as much as you can. So whenever possible, listening to EMS handover, even like eavesdropping on nursing sign over, and getting less of this second and third hand information and histories. If you can be right there when you're hearing it from the horse's mouth, you're a lot more efficient about gathering an appropriate and accurate history. 4 is maintain flow. And this really, you'll see redundancies coming up here in these articles, same thing that we've talked about, but renamed a different thing. This is a lot of where they're talking about sorting through how you see patients, the order you see them in, not necessarily the order that they're put up in. So they give the example of you have to dilate an eye to do a retinal exam, freeze a laceration, and you've got a 92-year-old who's weak and dizzy. Why not dilate the eye, numb the laceration, then go over, do the long history on the 92-year-old that's going to take a bit more time to work out. And by the time you're done that and you start that workup, your other 2 are literally ready for the 2 procedures you need to do there, as opposed to flipping it the other way. You probably get more efficient doing it this way. Obviously, it all depends on patient stability. This idea of sorting through the way in which you do things and coming up with a more efficient way of getting through them is very, very, it comes up again and again in the articles I've read. And then finally, delegate effectively. We have a lot of physician extenders at our disposal, clerical staff, medical learners, nurses, RTs. They're hugely helpful. So use them in appropriate ways and obviously reward them with praise and coffee, they suggest. And then finally, disposition. Again, we're all about disposition in the emerge. We should be thinking about disposition from the very start with every patient we see. They talk about setting the stage in the initial encounter. If it's someone you anticipate, I'm going to do some tests, I think they're going to be normal, and then you'll be good to go home and follow up with your family doc. Tell them that up front. It really does smooth away your reassessments and your discharge talks in the end when you kind of prep them for what you think their journey is going to be through the emerge. strive to make a decision on disposition in a timely manner. They suggest 4 hours. I'm hoping it's sooner in a lot of respects for us, but obviously it depends how complex they are. And enable a diagnostic strategy that allows you to make that decision by that point. Only order the tests that you need. Don't order tests that aren't going to change your management on these patients. And then consultations in 60 seconds or less. I think we're all pretty good at this in the Emerge, but trying to get out really the key things to your consultants in that first minute as to what's the bottom line, what's the patient's stability, and then why am I calling you, i.e. why do I need you? And then finally be flexible. Again, we're in an ever-changing environment. Every shift is different. Every day is different. If we're rigid in our stance on things, it's very hard to adapt to that changing environment. This next article, this is actually just a wrap-up line from this article, which I found was oddly fitting. So again, this was 18 years ago. With the current crisis of overcrowding in the ED, it's easy to feel incapable of affecting change. So clearly overcrowding was a crisis 18 years ago and we still haven't fixed it. But they again mention, while advocating for it is praiseworthy, you can find some sort of level of satisfaction in improving your own personal efficiency and seeing the difference that it makes as you negotiate the chaos of the ED. It was hard to imagine this was 18 years ago because it just sounds so much like every day that we negotiate in our environment. So I'm going to talk about something called diagnostic pathophysiology. So they make the analogy to the Frank-Starling curve. This is from that Kevin Clower article that I mentioned early on, was the 14 tips from ASAP's website. And if you consider the Frank-Starling curve, stroke volume increases with left ventricular end diastolic volumes. So the more the heart fills, the more the heart pumps, if you remember back to that. However, there's a point where more volume causes decompensation and reduced stroke volume. Our efficiency in the Emerge is really no different on an individual basis. The more patients we acquire, the more tests you order, the more you accomplish until the wheels really start to fall off the bus. Then you start to make errors, patients wait longer, you're tying up beds. So you need to know your point of decompensation. I want to emphasize that if you just keep picking up chart after chart after chart, you will reach a point where diagnostic pathophysiology ensues. I'm guilty of it. I've definitely done it. We've probably all done it, where we've grabbed a little too much and felt overloaded. Physician productivity is definitely a numbers game, but it's not all about numbers. They also make the analogy to your brain being like a smartphone. And I love this, too many apps and programs running and all of a sudden your phone is sluggish. It has no battery life. It's not as sharp as it should be. Patients and outstanding tasks are like those open apps in your brain. So you open less by ordering less. You shut down apps and programs by dispositioning them as soon as possible. Make use of your idle time so you can complete those outstanding tasks. And then you can have your brain performing like a top-end smartphone and not a bogged down old model smartphone. At the same time, I think we have to not hesitate to challenge ourselves. One of our newer staff, and I'll keep them anonymous, has taken to doing this, and I think it's very, very admirable. I recall having a discussion with them as a resident about strategies to improve productivity. So this learner, this staff at that time was already thinking about efficiency and flow, which I think is important. And I recall in their first couple months of practice, them saying to me, you know what, I had an hour left of my shift and I was feeling pretty tired, pretty cognitively fatigued, but I challenged myself to go over to the urgent area and see 4 more patients. And that's how you train yourself to manage a bigger cognitive load. It's not any different really than kind of athletically inclined where you have to train and build up to do things. Our job is the same. You do have to train and work at it and push yourself to get to that point. So again, I've been talking a lot about productivity and efficiency, but how do we measure it? I'm talking about how you increase it, but if you can't measure the increase, then improvement's kind of hard to characterize or monitor. So there's some numbers out there. Patient per hour is the most commonly used metric. It has obvious shortcomings. It doesn't take into account patient complexity. We know that it drops off with every hour of your shift, so it's not a constant number, but you can average it over your shift.
Join the meeting.
And we know that it's quite variable based on shifts as well, but it is the central metric that's used in most fee-for-service models. So, I mean, it's an important one to bring up. RVUs is an American system. I like elements of it in that it takes into account an individual medical service, how much time that service takes, how much malpractice cost is associated with providing that service. It even takes into account geographic locations and has different multipliers that they use in the States for this. So I mean, there's aspects to that that are a bit better than patients per hour. I think probably the gold standard is going to be for Emerge physicians, creating a unique productivity index that encompasses multiple metrics, probably including but not limited to patients per hour, case acuity distribution, procedures, shift variation, because as we would all know, days, evenings, weekends, working exclusively in the urgent area, exclusively overnight, or if you're Charlotte County, Sussex, they're all very, very different places to work, different times to work, and as such, your mix of cases you're seeing and your numbers are different. But I think patient productivity and physician productivity index is probably the best overall idea. Whatever you measure, it's got to be very department specific. Previous department I worked in had a really nice system. They just sent you your stats every 6 months. So you got a printout of what your patients per hour were, your consultant and radiology usage, your bounce back rate. And you just got to kind of compare yourself to your colleagues. Your colleagues were all anonymous and you just saw where you ranked in it. And I think we're pretty self-aware people as physicians. So it allows you to kind of undertake some self-reflection and make your own conclusions in your performance. So I kind of like that, that approach on it. This is a department in Saudi Arabia that basically created their own productivity index. They were having overcrowding issues. They wanted to measure productivity and see if they had major outliers in their department that they could then sort of investigate the causes and the reasons why. And they were left with this index at the end that they came up with. And again, it took into patients per physician, patient acuity level, and then treatment time, and kind of had a unique kind of equation that they then used to make the index. This is a Canadian study, which I found quite interesting. This was basically just pulling all of the numbers from their tracking system. This is out of Halifax, and seeing if there were any predictors of seeing more or less patients, having higher bounce back rates. They found some interesting things. Obviously, this is not, it can't be broadly applied because it's a specific department. They found actually that designation in terms of your training made a difference. So CCFPEM grads in this department tended to see more patients per hour than FRCP grads. They found a bunch of factors that seem to predict lower patients per hour. So more imaging tests, older physicians, female physicians, and then if you consulted more patients who were of a C-test level 3, and then more patients being seen by a learner. All of these things would usually push you over to seeing a lower patient per hour rate. On the flip side, they looked at higher return rates sort of as a metric of quality of care. And interestingly, it was the flip side of a lot of the things that I just talked about. So you tended to have a much higher return or bounce back rate if you CT imaged less patients, if you were a younger physician, if you were a male physician. And then interestingly, if you had less patients seen by a learner. So it seemed that patients being seen by a learner kind of, in a sense, made you more thorough, which is a kind of interesting thing in this department. So in terms of measuring productivity, this will kind of be my final wrap up on that. I don't think there is a perfect measure, but it's probably some unique index that takes into account multiple metrics, particularly because you have to also take into account quality of care, bounce backs, that kind of thing. If you aren't measuring it and tracking it, I think you probably should be. But I think if you're putting too much emphasis on it, you're probably going to also be detrimental and potentially encourage poor care. Any other profession where you work in a large team would take into account and probably actively measure your work productivity and efficiency. Anyone who's worked outside of medicine in the private sector would be used to deadlines, quotas, expectations on your productivity, and your boss or manager would then address it with you and try to support some form of mentoring or improvement. So I would argue, I'm not sure that we should be any different. We certainly made to have a unique way we look at it, though. The idea of ED bottlenecks is not new. We're usually talking about it on a systems-based level. But what I would advocate is each of us can undertake some type of critical self-reflection and identify our own personal bottleneck. For me, when I think about it, it's reassessment land. That's exactly what came up early in this talk. My strengths are normally continuing to see patients as my shift goes on and not having my patient per hour rate drop off. But as a byproduct, I'm the physician that gets bogged down in reassessments. And then all of a sudden I'm hogging all these beds and I'm taken out of the game because I've got all these patients to reassess and disposition. So for me, a lot of the strategies that came up to avoid reassessment land are big things for me to maintain a high productivity. And I find that setting the stage early with patients on expectation of admission or maybe a higher level imaging test or going home is important. That helps me a lot. And in particular, doing that kind of cognitive exercise of what is their path through the emerge, that helps to lessen that cognitive load and makes it easier to feel like you can pick up another chart. I'm pretty much done. I have basically 4 or 5 high yield tips or tricks that came up. They were kind of ones I picked out from the articles I read that I thought were particularly useful. So I will work through those quickly here. I think I'm just at the half-hour mark, and then we can break for a bit of discussion. So communicate your plan with your nursing team is hugely important. it is really worth taking that extra 30 seconds to talk to them when you leave the room and tell them what you've ordered and why and what your expectations are for the patient's path through their emergency visit. You can't expect that they're going to see everything that you've put in the computer. You can't expect they're going to do everything in the order that you would do it. So that face time and that quick 30 seconds is really worth it. Finally, and this, if I could advocate any tip that came up that I absolutely loved and I think is so important, is trying to ride the wave, kind of an analogy to surfing. So this comes from an article written by an emerge doc out of Texas named Elliot Trotter. And he actually is in charge of the flow month for the Parkland ED residents in Texas at their department. That's what they come here to learn from him and from his department. Efficient physicians love coming to work. He says they thrive on that challenge to keep up and organize the chaos and then work in the zone. And for the sports fanatics out there, the zone, again, is what professional athletes refer to as that ultra focus feeling, where typically during like a wave of patient volume for us, some other staff or colleagues might become frustrated, having trouble keep up because it's just these constant ambulances rolling in. And you'll hear them sometimes describe, a shift is a marathon, not a sprint. But to a highly efficient emerge physician, it's actually not a marathon. It's a series of multiple sprints during the shift, tidal waves of tasks and patients. And you sense that wave, you start paddling hard and fast, and you get up on the board like you're surfing, and you ride the wave down. And when the volume picks up, if you can dig in and keep up, most of the time it's going to slow back down. You can catch up. As I pointed out, there's obviously a balance. You can't be that physician that has higher misses and lower patient satisfaction in order to see those numbers. But this idea of trying to sense the wave, ride it out is huge. And then I think you have to employ a lot of the other things we talked about in order to be able to do that. Order tests in parallel. This is something I always go over with our learners. Decide what you want up front, do all the tests at once, and already have decided what you're going to do if they come back normal. Assume all your tests are going to come back normal. And then when they do 2 hours later, it's not such a big deal to decide what to do. You already decided that. And again, this also comes back to having a plan for everything. You should plan for every test you're going to order. Why am I doing it? What's the value added? It's not going to change my management. Do I even need to do it? The long pause. So this came up on a few different articles. So much of this talk is about emphasizing speed and numbers. But if there's any time to really slow down and take the time for the long pause, it's at that final disposition point, whether it's admitting and writing holding orders or setting everything up for a discharge. This is that time when slowing down really does pay off in the long run for you. This is the only thing I've really put in that's opinion-based for myself, hence I've quoted my own talk in it. But basically, I think filling idle time by completing tasks is hugely important, and I harp on our learners about it. There's pretty much always something that you can do, even if there isn't a chart on the board to see. It's not the time to necessarily check your phone or your email. I like to run the list, see what's on the go, and see if there's any tasks I can check off. That's like shutting down those apps on your smartphone in your brain. Things like discharge prescriptions, catching up on charting, discharge consults, running over the patient's complete med list. And honestly, it's a really efficient time if you're anticipating an admission, you're running over the med list, to just start jotting down their key meds on a holding order sheet. It's there and ready. Sometimes you end up tearing it up and not needing it, but you're also going through that exercise of running their list. And I find if you can really fill your idle time with these, get these things done, it makes it a lot easier to ride that wave when the volume builds and be able to keep up with it. Choreograph your shift, we already talked about. That's kind of the idea of streamlining your movements through and planning what you're going to do next, changing the order of things a little bit. And then finally, I'm not a fan of shotgunning tests, but there's a way to shotgun tests efficiently to improve things. This has come up in one of the articles written by Sam Campbell in this, that there are times under like extreme department bed crunch that shotgunning some labs actually does help you in terms of your ability to flow patients through the emerge. That is the end of my tips and tricks. So that's all I've got for you guys. We can open up for some discussion or some comments.
So Paul, I'm going to chip in and say thank you, first of all. Thank you for this as a department head. This is wonderful to hear. It's great for everybody to have a chance to reflect on this. Unfortunately, we don't have a whole lot of time because it's 2 talks in an hour, and we're already at 9:39. So we're probably going to have to move on. But I do want to just emphasize a couple of things you said for the group, for those who joined. And I really think it's important that we're all part of a team. And while we can become efficient, if we're not in an efficient team, then that can be problematic. So like you say, thinking of those around you, the other consultations, the nursing staff, having our systems in place, because it's really ED efficiency that matters in the end, not just physician efficiency. So thank you for that. Thank you for showing the balance. You can be really fast, see a lot and consult them all, or you can send them all home, they come back the next day. So that I'm glad you touched on those points. And I do want to think that patient-oriented outcomes are actually as important as the volumes, but patients don't have good outcomes if they don't get seen. So thank you for all of those great points that you brought up.